I think that providers know that when a patient has dyspepsia, H. pylori is something to look for and to treat if it's present. However, when patients come to see us, they don't come and tell us that they have dyspepsia. They tell us that they have a whole host of symptoms that really do fall under the categorization of dyspepsia. So dyspepsia, by definition, is discomfort that's localized in the upper abdomen. Now, this is a broad category, but it encompasses many common symptoms such as bloating, such as nausea, a sense of fullness after eating, or epigastric or upper abdominal pain. So when patients come in with these conditions, there is typically a desire to get them to feel better quickly, and a medication is often prescribed without looking for an underlying cause, such as H. pylori. When a patient presents with uninvestigated dyspepsia, the guidelines suggest that the first step in the management should be testing for H. pylori with a test of active infection, such as the urea breath test or the H. pylori stool antigen test. This is not always done in clinical practice, and what sometimes happens instead is that the patient is referred for endoscopy, or in other instances the patient may be prescribed a PPI. And the reason it's important to test for H. pylori before these things are done is that with respect to endoscopy, endoscopy is typically reserved for patients who are at higher risk for underlying gastric cancer. When someone is under the age of 60, and if they do not have the so-called alarm signs of weight loss, dysphagia, early satiety, vomiting, those individuals are highly unlikely to have underlying gastric cancer. So performing an upper endoscopy on them before performing a non-invasive test for H. pylori is really taking a very invasive procedure and subjecting them to that when the answer may be that they have a treatable bacterial infection that can be diagnosed non-invasively. With respect to PPIs, when a PPI is started, it's often continued. Many people who start on a PPI become chronic users of a PPI. And as we have learned over the years, PPIs are not entirely innocuous. They are associated with a lot of long-term side effects. The most well-established is an increased risk of fractures, and this has been corroborated in multiple studies. The other well-established long-term risk of PPIs are low levels of magnesium and vitamin B12. There is data showing association between long-term use of PPI and chronic renal disease, heart disease, cognitive decline, and other conditions. It's important to note that these are associations and causality has not been established, but it underscores the importance of making sure that someone needs PPIs before putting them on these medications long term. Checking for H. pylori before prescribing a PPI allows us to identify the group of patients who have a reversible and easily treatable cause of dyspepsia, which once it's identified and treated, gets rid of dyspepsia and essentially makes those patients better so that they don't need a chronic medication with potential long-term side effects. Guidelines from the American College of Gastroenterology recommend testing for H. pylori using tests of active infection. Tests of active infection are the urea breath test and the H. pylori stool antigen. And these tests detect actual bacteria that is infecting the patient at that time. These are in distinction to tests of prior exposure, such as serology, which the guidelines discourage using and advise against using. The reason serology is not a good test for detection of H. pylori is because it really shows previous exposure. When someone is exposed to H. pylori, they make antibodies against it. Those antibodies remain in circulation and remain detectable for years or even the lifetime of the patient, even though the infection may have been eradicated. So if a patient had H. pylori, it got treated, and the infection got eradicated, 5 years down the road, if you check serology, it would still be positive. What this does is that it raises the likelihood of false positive results. So with a background prevalence of around 20%, which is what we see in much of the United States, a very high percentage of positive test results based on serologic testing would be false positives. This would lead to a lot of unnecessary use of antibiotics and all the complications that go along with overuse of antibiotics. The current paradigm for the management of H. pylori is to test for it, to treat it if it's present, and to retest 4 weeks or more after completion of treatment to ensure that the infection has been eradicated. And the reason that we should retest to confirm eradication is because antibiotic resistance is quite high, particularly to clarithromycin, which is a mainstay of treatment regimens for H. pylori. There is resistance also to fluoroquinolones, which are used as one of the regimens to treat H. pylori. Up to 30% of patients, and in some communities maybe even more, might fail treatment to H. pylori. And by retesting, we are identifying these individuals and we are targeting them for retreatment so that their symptoms of dyspepsia might improve, and more importantly, so that we can mitigate their long-term risk of peptic ulcer disease, and gastric adenocarcinoma, and mild lymphoma. The value of testing for H. pylori as the first step in the management of dyspepsia is in delivering evidence-based care that is adherent to existing guidelines. It really results in appropriate use of antibiotics. It results in appropriate use of invasive procedures like endoscopy, which are frequently overused and are not without expense. So I think it allows us to deliver excellent outcomes at great value to the healthcare system. So it's really a cornerstone of providing value-based care in gastroenterology, because dyspepsia is a very common complaint that we encounter in gastroenterology and indeed in the primary care office as well.